Good afternoon and welcome to This Week in Digital Health. I am your host, Mike Doherty, and we are with Dr. Emilia Molimpakis. How did I do?
Yes.
Close?
That was fantastic. Yeah.
Okay, thank you.
Really good.
Of thymia AI. She is the recipient of the Young Innovations Award for 2021. Thymia was named one of the top 21 companies in mental health worldwide. And by background, she has a PhD in philosophy and neurologistics, which I probably just mispronounced as well. And, I know that you were a video gamer and scientific researcher, so that's a lot going into this. So tell us a little bit about what led you to this direction.
Yeah, absolutely. So arguably it wasn't such a smooth pathway, let's say. It's not what I set out to do, essentially. But so we founded thymia, me and my co-founder, about a year and a half ago now. But before that, I was actually a researcher for quite a while. I worked in academia for roughly 12 years. So I did a PhD and a postdoc at UCL, and my specialty was cognitive neuroscience and linguistics. And essentially, I worked for all that time with various patient populations, specifically people with mental health issues, cognitive disorders, started with Alzheimer's disease, Parkinson's, and then moved all the way through to mood disorders, including schizophrenia and depression. But for all of them, I would always approach them in a very similar way, which is my research focused on how we can use language as a biomarker for their cognition. And by language, I mean both the acoustic properties of how somebody sounds, so the physical sound waves, but also the content of what they say, so the semantics, the syntax, etc. And these are really, really interesting and good handles for you to understand how somebody is thinking and whether everything is working as we would expect it to be, or if there are any issues, essentially. When I was doing my postdoc and towards the end of my PhD as well, I was working with a video game company on the side. It was quite a small one, but I was doing a very interesting project, like helping them develop this video game where the game levels got progressively harder as you went on, and it was based on neuroscience protocols. So as I said, like very interesting as a concept. However, what happened while I was doing my postdoc and working with this company, my best friend at the time, also doing a PhD, ended up developing depression. So this is quite common with academics. And like a lot of people, she tried to go through the UK mental health care system. But unfortunately, again, like a lot of people, she fell through the cracks in the system. And so though she was being seen by someone, she had seen her GP, she'd been referred to a psychologist and then a psychiatrist. Within just 3 months, she unfortunately ended up trying to kill herself, which was obviously, like as a best friend, very hard to go through because I didn't see how bad it was. But what shocked me was, okay, I'm not a specialist and I couldn't see what was going on, but her psychiatrist and her psychologist, surely they could tell that this was this bad. Like it didn't have to get to this point. And that's what prompted me to really start looking into how psychiatrists, psychologists, and even GPs actually go about diagnosing and assessing and monitoring mental health issues, particularly depression. And I realized actually that the system is remarkably flawed. There are incredibly subjective assessment systems in place. There are these questionnaires, essentially. There's a few quite well-known ones like the PHQ-9, where you're essentially asking the person, okay, you say that you feel sad. On a scale of 0 to 4, how sad have you felt in the past 2 weeks, or how tired have you felt? Like you're really leading the person.
And it's very subjective, right?
Exactly. Yeah, it's so subjective. And all these studies have shown that actually when you ask somebody right here and now how they felt about the past 2 weeks, if they feel bad now, they will retrospectively consider the past 2 weeks to be bad as well, or vice versa. And so you're not actually getting the full picture. So I realized actually a lot of the stuff I was doing during my PhD and my postdoc, these biomarkers essentially weren't being used by clinicians, but I could help them by bringing them into the industry. And also if I realized also if we tweaked the video games similar to the ones that I was developing, if we tweaked them a little bit, we could use them to target patterns that are typical for depression. And so that's where the idea for thymia essentially came. So through personal experience and life factors, I ended up leaving academia and I joined Entrepreneur First. It's an accelerator program. Here in the UK, there are other outposts in, I think there's in Paris, in Berlin, various other places. And I was looking for somebody to help me build thymia. And that's where I met Stefano, my co-founder, and he was just the absolutely perfect match in terms of skill sets and backgrounds. And so, yeah, that's how thymia was born. Quite long-winded, but it's the full story, essentially.
And Stefano is a PhD in philosophy as well, right? Both of you.
No. So I have a PhD in neuroscience and linguistics, and he has a PhD in theoretical physics.
Okay.
It sounds like a bit odd, right? So why would theoretical physics actually be relevant at this point?
Right.
But actually, the relevance comes from the fact that after his PhD, which he did about 9 years ago now, he worked for roughly 8 years in large investment banks as a quantitative analyst. And there basically, he specialized in building machine learning models that combine modalities of data. So different modalities like text, like sound, like speech, all these things. And he was building models to help traders trade on the trading floor, essentially. But the same models that he built there can actually be used with our data to help assess and monitor depression. So it's very, very amazingly overlapping skill set there for me to use to help me build thymia. And also something really interesting that's he has a specialty in something called ethical or explainable artificial intelligence. I'm not sure if you're familiar at all with the term. Maybe your listeners aren't, so I can go into it a little bit. So your typical AI, and this is something also that sometimes gives AI and machine learning a bad rap, is that you don't really know exactly what's happening in the model. It effectively works as a black box. You put stuff in and it computes and then it spits an output, and you have to trust the process. What explainable or ethical AI tries to do is essentially it cuts a window into that black box so you can understand why the model might suggest something. And so then you can also question it and say, is this really actually what we expect it to find? So it helps you deal with a lot of biases that are inherently, unfortunately, always incorporated into these models, like biases against race, biases against gender and age, and explainable AI helps you detect these and correct for them, essentially, which is super important for mental health.
And how was the transition from research and theoretical to, you're out in the real world, you're building real products. How was that transition for you?
I think it was incredibly interesting, exciting, and also very challenging. It was a very steep learning curve. I think when I first kind of had the idea for thymia, I didn't really understand entirely at that point, like how big it would get and how impactful. Of course, I wanted to be super impactful, but the scale at which we've grown and the speed and the enormous amounts of data we collected has been absolutely amazing. And I think that was the amazing thing about transitioning from academia to the industry and to creating your own startup. The best thing was from the moment you have this idea and you think of something and you know you can make it work, to actually having it implemented and working and gathering data, and then of course also selling it. The time frame is so small. It's amazingly quick turnaround. That was the best thing. The other thing was, of course, dealing with investors and things like that, which was not something I knew, and that was not great. But we navigated that, and it's been, I would say, a year and a half. I would not change any of it. Absolutely, no, it's been fantastic.
It's interesting. Having been an investor, we are always leery of the academic types, right? Yeah. Because in our mind we're like, that's nice, but have you ever built anything? Have you ever sold anything? Yeah. How did you overcome that?
There was definitely a lot of bias, I think, against the fact that I came from academia. Stefano was from the industry, but he had never built products to sell directly to consumers. He was always within this big corporate environment. So there was definitely a lot of apprehension, I guess, in the beginning about us, and also apprehension. I think this is going to sound really bad, but actually, I did get quite a few investors who were they didn't really like the idea that I was a young woman and the CEO at the same time. So combine that with the academic.
Yes, when it comes to women in leadership, and especially
exactly.
in startups.
Yeah, especially in tech as well. Like, it's very unusual, and I did get that a lot. Oh, hey, your co-founder is the guy. Why isn't he the CEO and you're the CTO? And like, that's not how it works. But I think essentially what we were able to show was, look, we can talk the talk, but we can also walk the walk. And this is an amazing project. Look at the traction we have. Like, people love this. These are our numbers. These are our statistics. These are the data, and we're closing really big deals. So I think essentially the traction and showing them how good our models were was what changed their minds, that you're not just great academics, you're also great at designing and delivering something. So yeah, we were very lucky to kind of emphasize at the right point, I think, the design of thymia. So if you see our website and if you have the opportunity to interact with our product, it's incredibly beautifully designed, and that was thanks to us investing a lot of our initial funding into, product design, working with this amazing illustrator and design team in South Africa, and they really helped us create this feel for our product that was calming and also engaging. And through iterative feedback through patients and clinicians, we made it even more so. And that's everything: the colors, the style, the feel, the movements, everything is made with patients in mind and with their feedback. And that's what makes it work, because they come back and they love it. And that's the only way the product can work, essentially. So we were very lucky to do that straight away early on. I guess I would like to say it was insightful and everything, but at the end of the day, it has become like a really big part of thymia now.
And so this is a diagnostic tool?
So I'd like to shy away from the term diagnostic, because that's not its intention. Its intention is to provide clinicians with as much additional objective information as possible, combining the modalities of voice, video, and behavior through video games. We do not want to actually diagnose and replace the clinician in any way. We firmly believe the clinician has their expertise and they do what they do very well. We just want to empower them with more data because they need it. And also, clinicians are dealing more and more, particularly psychiatrists, with burnout and not being able to meet the demand. Mental health is, we're going through a crisis period, particularly after COVID, and we want to help them actually meet the demand, not replace them. So we are essentially more of an assessment and monitoring tool. In the future, we will also hopefully be able to assess very quickly whether treatment is working or not, sooner than the patient themselves can realize. And also in time, hopefully also predict what type of medication different people will respond better to. But always with the clinician together.
And the company, I'm assuming, is intentionally named thymia AI. So the AI aspect is to garner those insights earlier from the data patterns.
Exactly. Yes. So essentially, to explain how thymia works and what we do, when you think of depression and any other cognitive disorder or mental health issue, you're essentially looking at a difference in how this person's brain works. It doesn't mean it's worse or better or anything, it's a difference. And this difference is accompanied naturally by cognitive and behavioral patterns and changes in the normal patterns that you would see with people without this. And so what we do is we use these three modalities. We assess people's speech, we assess their facial expressions and how their eyes move, and also their reaction times and behavior in the video games. And through these, we look for these signature patterns in cognition and behavior. And each disorder has its own pattern. So this means we're starting with depression, we're looking for the signature pattern of major depression, but we also have the capacity to expand to any other cognitive disorder. So we've already started expanding to Alzheimer's, Parkinson's, Lewy body dementia, and also ADHD, and looking again for these patterns in each one.
And obviously there's, a scale of any of those. So you're also sort of looking at where they are in the progression, right?
Yes, exactly. So we are able to not only assess whether somebody does or does not have this particular disorder, let's say depression, but we can also quantify how severe or not the disorder is at this time point, and also how it progresses over time. So because our tool works longitudinally, each person becomes their own baseline, and we can continuously monitor them. So yeah, we can, the other big thing that we do is not just kind of like producing a category of output, we can also quantify the core symptoms of depression, which is something nobody else is doing currently, because you need all these modalities to do this correctly. So we can quantify fatigue, working memory impairment, changes in psychomotor speed, attention, and mood shifts, all through these different modalities.
And does the gaming process become a therapeutic itself?
That's a great question. I know there are companies out there doing, like, using gaming as a therapy in and of itself. Like there's Emilia Health who does this for ADHD, for instance. We haven't intended to become part of the treatment process. However, the feedback we've had and what we've seen is when patients use this kind of tool and they use it consistently, and then they're able to see the output over time, the fact that they can see a measurable objective difference in their behaviors in response, let's say, to treatment, actually affects treatment adherence. So you're more likely to stick to your treatment, which by extent also means that you'll get better.
And also, you're also able to provide insights over a period of time versus a point in time. Where typically the practitioner is seeing them in the office, that's a point in time. Like you said, depends on how they're feeling that day. And you're either able to look back over weeks or something to provide insights of like how they've been doing.
Exactly. Yeah, that's one of the biggest value adds of thymia. It's not just that we are providing objective information in a point in time to clinicians, it's that typically psychiatrists see their patients once every 4 to 8 weeks, and in between there's nothing. And if your patient's doing really badly, there's no way you would know unless they reach out to you. Whereas with thymia,
there's a 4 to 8 week gap between. Wow.
Yeah, so the clinical psychologist is slightly different. You'll see them more frequently, but psychiatrists typically it's once a month or once every other month. So you're dealing with a case of major depression. You're dealing potentially with something that, triggers an episode. Let's say it could be anything. It could be, the person gets fired, or the person is going through a divorce, or even less so, like the person, their friend moves away or something like that. Any of those things can trigger an episode. And as a clinician, you would never know. And the thing thymia does is we ask the patient to engage with us. It doesn't need to be every day. It's once every few days. And it doesn't need to be all of the different games or all the different activities. Just one here, one there. It allows us to keep an eye on them and to inform the clinician so that they always have an overview. And when they see the patient after 4 or 8 weeks or even a week, they can look back and say, oh, I see on this day you weren't doing so well. You were very tired. Can you talk to me a bit more about this? So you have so much more insight.
And with that baseline, will you create alerts when someone is going through a particular episode that you're identifying?
Absolutely. I mean, that is the goal. Naturally, you have to go through all sorts of regulatory processes and become higher levels of medical device if you want to take on the entire liability of that happening. But we certainly want to be able to alert the clinician anytime we pick up anything. We also offer through our platform the capacity for the patient to message us or the clinician at any given time. And we also have an option for them to, call the NHS helpline or whatever corresponding thing you have in the States or in Greece or anywhere else as well.
And does this platform provide, sort of like the gaming community where there's an environment to interact with other people on the platform besides the practitioners?
That's actually a really excellent idea. We haven't thought of that yet. At the moment, really, each patient kind of occupies the platform for themselves in isolation, just together with their clinician. The clinician themselves can have an overview of all their patients at any given time, can contact them, but the patient themselves doesn't actually interact. That is actually a really interesting suggestion. We could think about how to do that in different ways, potentially through the games. That could be very interesting.
Yeah, because typically one of the benefits is just the idea that I'm not the only one going through this.
Yeah, absolutely.
That's what the community provides. That this is normal, whatever normal is. This is comments, things like that, so that and they can interact potentially with others. So you have raised funding, is that correct?
Yes.
Okay.
So at the end of April, earlier this year, 2021, we raised £780,000 in funding, or $1.1 million. And actually, now we are very soon raising. Yeah, we're raising another round sooner than we expected, because essentially we have a lot of runway left for the money we've already raised, but we've had so much demand for the product. It's really, it's amazing, but you don't want to say that this is, you expect this or anything like that. So we have contracts now for over 80,000 active monthly users for 2022. We're negotiating further contracts to raise that number to potentially even 500,000 users. So obviously we need a lot more people on the technical team and support team to make sure that goes smoothly and everything. So yeah, we're ending up raising again.
And are you going direct to consumer, or do you have partners where you're selling into hospitals or practices, or how does that work?
Yeah, so we're a B2B business model, essentially. We go straight to mental health clinics, telehealth companies, mental wellness companies, and each of them has their own set of patients, and we just sell direct to them. Potentially in the future, we may go B2C, but for the moment, it makes a lot more sense to go B2B.
And one of the typical digital health models is, are you offering value-based care? Can you save money? Can you change outcomes? And how do you respond to that?
Yeah, absolutely. So one of the reasons we're successful as a B2B solution is because we do actually address a lot of the commercial drivers for these clinics. So of course, every clinic wants to save time, they want to save money, and they want to maximize revenue potential. So thymia, essentially through our assessments before the appointment and after the appointment, but also through the teleconferencing solution we offer, we actually end up saving clinicians roughly a minimum of 30 minutes per session. So if you have 45-minute sessions or 60-minute sessions, you're increasing the capacity for each clinician to see more patients. They don't have to see more patients, but the capacity is there. And particularly for the clinic, this is really good because, as I mentioned earlier, a lot of clinicians suffer from burnout, particularly psychiatrists. So this is giving them more breathing space and more capacity to handle more of the inflow. There's certainly there certainly is enough demand for mental health practitioners. It's whether they can meet it. The other thing we do really well, which is a commercial driver, not everyone seems to grasp straight away or understand if you're not within this system, is that we can help the clinicians to stabilize a patient much sooner than you normally would without an objective assessment system. And you may, let's say we're being incredibly cynical, you may ask, why would a clinician want a patient to be stabilized sooner? Surely we want them to come back again and again so that we can get more money and more revenue. Let's be completely cynical here. But actually, what you really want is a patient to be stabilized so that that patient essentially doesn't need to go and find another clinician who will find the right treatment for them. Ultimately, the clinician and the patient, they want the same thing. They want stabilization, they want the right treatment. Typically, it takes 3 years for a patient to find the right treatment for depression, but it could take up to a decade. We recently had somebody tell us that in the clinic they were actually undergoing a potential lawsuit because they had misdiagnosed somebody as having depression when in actual fact they had Lewy body dementia, and this had been ongoing for 10 years. So we
So
create a lot of
unfortunately not
value
that
there as well.
uncommon, right?
Exactly, yeah. So even if you want to be completely cynical, which is not our intention, like we want to make sure that we are helping the patient and we are helping everyone. Our goal is to make mental health as openly spoken about and as objectively measurable as physical health. The fact that we can help the clinician save money just basically means that they'll use our system.
And does the AI provide indicators for earlier insights than we might in the other environment? So can you see things earlier?
So that is definitely one of our goals. So your average antidepressant medication typically takes, unfortunately, 6 to 8 weeks to actually be perceived to have an effect by the patient and to be observed by the clinician. A little known fact about some antidepressants is within those 6 to 8 weeks, one of the common side effects is they can actually make you more suicidal, which is not a desired side effect or outcome in the best of cases, particularly not with depression. Yeah, so essentially what we are aiming to prove out over the next year or so is that we will actually be able to detect a difference or a response in treatment within the first 2 weeks, maybe even the first week, which means if there's no response, you change straight away.
Right. So, so an early indicator so that you can pursue another course of treatment.
Exactly, yes. And the other more ambitious target is to see if actually we can use the biomarkers we have early on, straight from the first assessment, to detect or predict which treatments this particular individual is likely to best respond to, which isn't even further. You're bringing the treatment response even further forward. So you don't have to go through 1 or 2 weeks, you go straight away to the right one.
And I'm also guessing that what you're looking for is, you're looking to avoid any kind of acute incidences.
Yeah, absolutely.
And you're looking for indicators that might suggest that they're going in that direction.
Absolutely, yeah. So it's very important to understand that with any type of mental health condition, like physical conditions, there are good days and there are bad days. And one of our targets is to be able to detect the difference between the two and to be able to prompt the individual or the clinician to do something about it.
To intervene.
So absolutely, yeah, absolutely. And that's not just true for major depression, it's true for bipolar disorder, it's true for autism, for ADHD. There's always ebbs and flows with all of these conditions, and having eyes on it at any given point is so important.
Yeah, I think what you had mentioned, the idea of stabilizing, right? There is ongoing treatment. We're not suggesting that would discontinue, but we're looking to avoid, the big acute events where they end up, in the emergency room or some other event
Exactly.
like that.
Absolutely, yeah. The other thing that we're also hoping to help with is detect early depression in people where you're not necessarily expecting it. So people, let's say, who may have gone to the doctor for a different reason, or in mothers after birth, let's say, if you use a system like ours, potentially we can detect that something's changing, which could also be very helpful for clinicians.
Depression is a common side effect for most of the chronic illnesses, right?
Yes, absolutely. Yeah. That's also one of the reasons that we always ask anyone who interacts with our platform, whether we're talking about the patients who we're gathering data from or the healthy control group, we always ask to understand what other physical conditions they may or may not have, whether also they have things like asthma or any of those things that could affect the outcome or the output of our models, and things that could affect your voice. All these things quite often and frequently interact, and you have depressive episodes in these individuals. So it's good to understand what you're dealing with, essentially.
And what are the challenges in moving from different conditions? From, like you're talking about, depression is one set, but Alzheimer's is clearly different. So how do you manage that?
Yeah, so essentially this comes from being able to use all these different complex modalities. It means you get a very comprehensive picture and understanding of the individual as an individual. And by extension, you also get an understanding of each of the disorders. So as I mentioned earlier, like you have this concept of a signature pattern. Each disorder has its own signature pattern. And for us to be able to detect depression, it's very important that we understand depression's signature, but also that we understand the other ones so we can distinguish one from the other. When you're looking at Alzheimer's, Parkinson's, Lewy body dementia, all of these also have very strong speech indications, very strong indications in terms of body movements, eye movements, facial movements, and these are exactly what our models detect. We also are using a concept called reinforcement learning, which is quite a new AI concept, which means you can essentially use the models you've already trained with a specific disorder, and you can use those models to bootstrap the next ones, which are targeting a different disorder, which means you can, every time you move to a new disorder, you effectively decrease the amount of data you need to get the same level of accuracy in your models, which allows us to kind of piggyback on our previous success and move on. And so it's essentially a combination of pre-existing models, understanding the disorder really well, and understanding the signals that we need to identify, and also gathering a very large amount of data to make sure it's properly trained.
And are your services currently available in the UK? Where are you right now?
Yeah, so our original market is the UK. So we are selling here to private mental health clinics, mental wellness companies, etc. We were intending to stay in the UK for a while, but actually we had a lot of inbound interest from the rest of Europe. So we ended up expanding quite quickly to Southern Europe. We have clinics now who are using us in Greece, Spain, but also other areas. So Brazil is a very big customer. There's unique.
So you have multilingual issues.
Yeah, well, it's not actually an issue for us because our models are language and culture agnostic, okay. And each person becomes their own baseline. So it's more of an issue, let's say, if you think about it with accents within the same language, that can also become a big thing linguistically. But because we ensure we gather data from literally tens of thousands of individuals to train our models, but we also longitudinally monitor the same people, so we can control for these factors, essentially.
And when you raise the new round of money, so I'm assuming this is expansion and growth, where will you target? New diseases, new geographic?
Yeah, so the aim is by the time we get to our Series A round, we want to have also expanded to ADHD, bipolar disorder, Alzheimer's, and Parkinson's, and also have expanded to, as I said, Europe, Brazil, potentially the Middle East. We have a lot of interest there, but we're still evaluating whether or not this is a good idea. Then for Series A, we would expand to the States. Essentially, we're aiming to raise our Series A round there.
And what does the competitive landscape look like?
Yeah, so this is actually also a great question. So we are the only company as yet to combine multiple modalities. There are plenty of other people out there who have tried to address depression or Alzheimer's, various cognitive disorders with a single modality. Most typically, this would be voice. So quite a big competitor in the States, for instance, is a company called Ellipsis Health. They do depression assessments via voice. Sonda Health also in the States do something similar. However, when you only have one modality like voice, there are certain issues essentially with running your platform in that way. While voice is great and it has a strong signal in the lab, in the real world, you can't really rely just on voice in order to make these assessments, particularly not longitudinally, because quite often you deal with the concept and the issue of noise, both metaphorically and literally. Literally, you know, if the microphone isn't working or there's a child screaming in the background, there's a dog barking, it's going to affect your model. But quite often with depressed individuals, you have the issue that they don't want to talk on a given day. They don't want to open up their phone and you know, start talking to it. Whereas if you have multiple modalities, first off, your model is a lot more accurate because you have multiple different signals coming in. but also it's robust because you can just fill in the gaps in other ways. So for us, a lot of patients don't really necessarily want to talk. They just want to play the video game, and they're completely fine to do that. And we will still gather data and be able to get insights on that particular day. The other thing is, if you just use one modality, it makes it incredibly hard to expand to other disorders. Hence why a lot of these other companies just focus on one. Whereas for us, it's super easy to actually expand. And indeed, we already are. So although there are other companies, there's nobody really doing it in the same way as us. The other big thing about thymia is we've addressed the whole assessment process as part of a much larger end-to-end solution. So we don't just go in and do a one-off assessment like a lot of competitors do. We don't offer our service just as a single API. Our service kicks in from the moment the patient first visits a clinician, and we follow them all the way through the treatment, aiding and empowering both patient and clinician at every single step of the way, which means we become a much more integral part of the system. We offer a lot more value. And also it means we get a lot more data through this end-to-end approach. And that's something unique. We are the only people to be doing that at the moment.
One of the things we've seen as a result of COVID is that digital health is doing really well as an industry. Do you think that people are more receptive to these types of tools as a result?
Absolutely. Yeah. So I think COVID-19 has in itself, of course, brought on a lot of other issues with it, mental health tsunami, as a lot of people have said, but also it has really accelerated acceptance across age groups of digital health. And it's opened doors to new ways of dealing with these things. One of the most interesting things I've heard recently, well, not recently so much anymore, but maybe like midway through the COVID crisis, was universities we were speaking with, the mental health departments at universities. They said to us, actually, students are doing much better at the moment than usual. And when we dug in a bit more, it was because students felt a lot more comfortable interacting with their therapist or with their therapy group through their phone, because this is what they're used to, and their response to treatment was much better as well as a result. So this is a very interesting, unique kind of new thing that COVID has brought with it. And I think also, for sure, we're seeing even 70-year-olds responding much better to this kind of digital solution. I think also there's like government mandates at the moment that are pushing for digitization of mental health. The NHS is a lot more accepting. I think the cogs would have turned a lot slower on this if COVID hadn't pushed really hard, essentially.
And which brings to mind, is this a reimbursable tool?
So at the moment, we're not working with a reimbursement model, but certainly it's in our plans to do so. Yeah.
Okay. Because that's typically a big.
Yes, it's a big thing for the States as well, and Germany and other areas. So yes, it's on our roadmap.
So what, so looking forward for the next year or so, what do you think your big challenges are?
I think one of the biggest challenges we're facing now is hiring in quickly enough to meet the growing demand. Of course, that's to do with funding, and it's to do with just how fast you can hire people.
What types of people are you looking for?
So we're looking for technical people a lot. So we're looking to triple our technical team. So you're looking for machine learning engineers, backend developers, front-end developers. We're looking for game designers to help us in creating more of the games. Illustration is very important as well. But also a few people obviously on the commercial side as well. But mainly it's technical and scientific. So that's one of the things. We were concerned initially that engagement and people coming back to the platform might be an issue, particularly for people with major depression. And if they don't, then this is not going to work, obviously, because it's a longitudinal model. But actually, we've been amazingly positively surprised by the reception. Over 95% of everyone interacting with the platform has enjoyed the experience, and over 85% of the users have said they would continue to play the video games just for fun, even without the output. And this was the same for 18-year-olds as with 75-year-olds. So across all age groups, those statistics are the same, which was very positively surprising. We were thinking, okay, maybe this is something that younger people will enjoy more, but actually even 70-year-olds really enjoy it.
Yeah, I mean, we're definitely seeing seniors embracing, digital. It's been around for a while that,
absolutely,
they get the benefits of it. So that, we're definitely seeing that. We very much appreciate your time today.
Thank you so much.
Enjoyed the conversation. We look forward to great things for you and your business partner, as well as thymia.
Thank you so much.
So we look forward to chatting with you in the future.
Absolutely. Thank you so much for the opportunity. It's been great chatting with you. Thank you so much.